And we're not going to go through bios at this time, but we're asking each presenter to share more information about themselves as they wish. But we have a really stellar group of folks today joining us from Chicago and Louisiana. We're starting off with Jeannette Webb with the University of Chicago. We're moving on to Chad Zawitz, who's with Cook County Health here in Chicago, works at the jail. Then Russell Brewer from University of Chicago, followed by Gjvar Payne with the Capital Area Reentry Program in Baton Rouge, Louisiana. And then Louise from New Orleans is going to round us out. And then we hope to have plenty of time for QA and discussion afterwards. So stick around for the whole time. I'm going to stop sharing my slides now, and I'm going to invite Russell to go ahead and share his slides and ask Jeannette to kick us off. Thank you all so much.
Jim, I actually think Miss Jeanette was having some computer issues.
Oh,
I think she's rebooting right now. Um,
so do you want to sort of help set the stage while you're pulling up the slides, Russell? Maybe you want to set the stage for our discussion while Jeannette reboots?
yeah, sure. So, yeah, I can go ahead and introduce myself. I am Russell Brewer. I'm a research professor at the University of Chicago. I'm also the director of health equity research for the Chicago Center for HIV Elimination. And today we really wanted to share with you all some of the work we've been doing for many, many years, focused on the PrEP implementation in correctional settings, particularly within correctional settings, jails, for example, and also immediately following a release. We're going to share, Ms. Jeanette was going to set the stage for the work that we've been doing over the years. And I was going to talk about one of the projects, well, a few projects. The first is the Justice PrEP project, which focused on examining PrEP implementation in correctional settings. And then I was going to talk also about the JRISE project, which is a status neutral project focused on improving HIV and employment outcomes among folks who have been impacted by the criminal legal system. And then we were going to have insights from two of our community partners in Louisiana. So I don't know if Miss Jeanette is back on.
Let me see. I don't see her back. Would it make sense to start your
Oh,
slide?
she said, she just sent me a text. She said she's coming back. She's coming back.
Okay,
Yes.
fantastic.
So we'll give her a minute, and then if not, I can go ahead with my presentation.
Okay, cool. We can all take a deep breath and just relax. It's beautiful Thursday morning, afternoon, evening, wherever you are. Thanks everyone for being here. This is such important work. I think, so, when people enter corrections, they tend to get forgotten by a lot of folks, including us in public health. So it's so important to be talking about providing these sorts of services to people who are pulled into our correctional system. Thank you to Russell and everyone for all the great work. And I should just say thank you to Russell for, I've been sort of chasing him around for the last, it feels like a couple years to get this webinar going. And thanks for, you know, not, for accepting my advances as they are. Much appreciated.
Okay. Yeah, Jim, she's on. I see her.
All right, there she
Uh,
is. All right, Jeannette, thank you. You're
all right.
here.
Let me go ahead and I can share the slides and then we can begin. Okay. Oh, 1 second. Okay, Miss Jeanette. Just let me know when you're ready to to go to the next slide.
I will indeed. Let's see. Okay, good morning, everyone across the globe. We thank you so much for joining us. I'm sure Jim has already given a welcome. So I just want to say thank you for being with us. Let's jump right on in. So I'm Jeannette Webb with the University of Chicago, Assistant Manager, Implementation Research, background in public health, specifically with correctional healthcare, correctional public health, that is, and would like to just glad to be a part of this conversation that we can really address a lot of these different issues. So lay the foundation for academic and correctional and community partnerships, focusing on holistic health in this day and age where the criminal justice system seems to come across as becoming more robust when seemingly resources are diminishing. So how can we kind of circumvent that? So where is all of this happening? What is part of this? It's in the jail area. Go ahead, Russell. So in looking at the jail, that's the purpose of our conversation today, and let's justify our conversation. Why do we need to have research there? Why do we need to have stakeholders and partnerships and champions to be in this area? And why do we even want to look at the incarcerated setting? Also, the allies. You cannot be an island by yourself. This problem did not happen by itself. It's going to go away by itself, and many hands make the job light. Very simple. Intersections, how these different challenges and situations come together to either create more problems or how it comes together to give us the opportunity for growth and development to move things along. And then we're going to talk about the lessons that we have learned in this journey thus far and how we can continue. Next one. So in justifying the focus, we know that the jail population, the incarcerated population, is one of the most marginalized in the United States. And we can say that almost definitely all across the board, that it is over-policed. They are areas that limited resources, and in some instances, people would even say in real life or real talk, tragically under-resourced. There's rapidly failing infrastructures, even in the best of areas. And so we know these areas that are lost to care, lost to follow-up, lost to power, that those infrastructures are declining even more, even quicker. Different levels of academic involvement and completion is a lot lower, unfortunately. And we see that because of lack of resources for school, lack of resources for proper nutrition at those developmental ages where children's brains are developing, et cetera. And then it cascades on to what happens in elementary school, high school, et cetera. So we see all of this all the way through the pathway for them going to a prison setting. So we know that the incarceration can impact social and sexual networks and stability and employment, housing opportunities in the United States. And I don't know about in other areas, but if a person has a felony, they're not allowed to live with certain individuals. If a person has a certain charge, they're not allowed to have certain housing, be in certain areas for housing. And if that's all where the housing is available, then that puts them in a vulnerable state of housing instability or lack of housing altogether. So we also look at this criminal legal involvement individuals identified as a priority population in the Getting to Zero Illinois project. So initiative that is. So in the state of Illinois, it is an initiative to try to get the HIV, meaning new cases, to get down as close to zero as possible in terms of providing services, access to PrEP, information about PrEP. Let's remove the stigma about testing. Let's remove the stigma about who you love and how you love. Let's remove the stigma about access to preventing HIV. Okay, let's go to the next one. So we've justified our conversation. So now let's take a look at our allies. And again, you cannot be in an island by yourself. It is critical to develop relationships within the incarcerated setting and with those who are the supporters of your reentry efforts. So here at CCHE, which is Chicago Center for HIV Elimination, we have been fortunate to create a partnership with Cook County Department of Corrections, also known as Cook County Jail. And we have many projects that have been through the jail with champions that are there that support the efforts of what the University of Chicago is doing, as well as reaching out for additional resources, as we also at U Chicago are trying to find out more about how we can help individuals in their reentry journey. So this happened before COVID, and then of course with all of the changes across the globe, we know there was changes at the jail. So even after COVID, we didn't give up. We said we want to stay in there, and so we're just doing what we need to do to follow the rules to be back in the system, to be able to be supportive. And then unfortunately, some they go from jail and they end up going to IDOC. And so that's Illinois Department of Corrections, which means now they have been found guilty and they are now serving their time. So when they go there, are they out of touch? Yes. Are they out of sight, out of mind? Yes. And so it's important that if we're trying to connect with them here, and we know a lot of them end up meaning the individuals, persons who have been found guilty of whatever charges, that they go there, but they're not forgotten. And in most cases, they are. The prison systems, a lot of them are very far away and their families can't get to them. Families have a hard time providing them some resources while they're there. And then when the person is released, it's challenging for them to come back to the community. So that's where we develop allies with partners like IDOC to be able to say, can we connect with some of the folks that we worked with while they were in Chicago, while they were a part of our system here, so that maybe we can understand the journey there, and maybe we can also understand how we can be more of a resource to them when they come out. So we also look at connecting with community-based organizations. There are a lot of talent out there. There's a lot of support, a lot of passion for helping individuals in that reentry journey. So why do we feel as though we need to do the burden by ourselves, handle the burden by ourselves? We don't have to. We shouldn't have to. And there's no need to do that. So creating those connections with healthcare systems and other reentry coalitions make this journey, make this job a little bit easier, but also helps us to collectively come together to empower ourselves as service providers and service supporters to be able to lobby for those dollars, lobby for those resources, or to speak for those populations that no one else would even think has a voice and no one even wants to think about listening to. So looking at outreach efforts, employers and those individuals, those places that are willing to give temporary housing, temporary employment, opportunities for internships, anything like that, that will help a person to get back on their feet, help a person to start over again, even if that's the case, because people deserve an opportunity to be able to reboot, try again. And this time, maybe having a partner to help them do that will help them be more successful. We're looking at opportunities to of information exchange and empowerment for both groups. And we have to remember that with allies, it is essential to make a network for both sides, because we can clearly see that there's a network in favor of keeping individuals incarcerated without supporting them, and in some cases without providing fairness. And that's where our partnership comes in. And in doing research to understand the challenges that they're facing, this gives us more information, more data, if you will, to be able to defend our position as to why this population is just as valuable as all others, because what? They're human and they deserve a chance. Let's go to the next one, dealing with the intersections. So the challenge is with this is that the same situation that possibly created the pathway to incarceration also creates the same situations that creates the pathway to those healthcare challenges. Lack of food, that is a serious problem across the globe. What will a person do in order to eat? What will a person do in order to provide food for their family? If they don't provide the food, the health challenges are many because of poor nutrition. But if they do provide the food, but they don't have a job, then if they end up doing something, whatever they need to do, we're not going to, label, but if they do something, whatever they need to do in order to be able to have those resources, then what happens? There's more of a chance for them to become incarcerated. Well, let's look at this. One of the ways in which they may do some activity, possibly sex work, possibly being in a situation they can't get out of in order to be able to have shelter and food, which may find themselves at risk of what? For this conversation, we're going to talk about HIV. So you see, as it says on the slide, HIV prevalence is 3 to 5 times higher in prisons and jails than in the general population. Could that be, is it happening in the jails? We know that it does happen there, but we're looking at also situations of what happened before they got to the jail. Did they have information about HIV? Did they have accurate information about it? Did they have information about PrEP, injectable PrEP? Did they have information about proper condom use or proper physical barrier use or chemical barrier use in those instances? Whatever those situations might be, do they have the access to having a provider to sit down with them and really talk to them and listen to them about what their challenges are? Let's talk about engagement through multiple client-facing opportunities. So our center, the Chicago Center for HIV Elimination, we are in a unique position to be able to handle those healthcare challenges, talk to them about healthcare challenges, get them connected to resources, but also study and collect information from individuals that are having those challenges so that we can have information to be able to say, we need to create better programs. We need to be able to be a part of the healing of the land, if you will, or the progression of improvement of situations which people are living. So consumer engagement, various consumer advisory boards like the CAB. So why would we be in this situation, and meaning being able to provide service, collect information, and not talk to individuals with real experience? So real life experience has its place. There are great champions and stakeholders that want to do this work, but individuals who have walked this journey, who have been incarcerated, who have been accused, who have been in those marginalized areas, they have a level of expertise, insight that should not be ignored and should be heard and should be given some strength to understand the plight of what is going on in the community. So therefore, having members of the CAB, what we call the CAB is Community Advisory Board, let's listen to folks before we put an idea out there to make sure that we're hitting the mark, to understand some of the nuances of what's happening for real in the street or in the community in order for us to be effective in our effort. And let's go to the L. Sorry about that. So with some of the lessons that have been learned in this journey, we know that correctional settings constitute an important setting for HIV care, treatment, and prevention services. Research in the jail, research in that space, it's a sad relationship, but it is needed because you have a group of individuals that are here that, you know, I hate to say it this way, people say it as a cliche, trapped individuals. They're not trapped. We're supposed to be the ones that teach them why they cannot stay in that trapped state of mind and that there's other options available for them. So having that partnership with correctional settings to get in there to work with individuals, we realize that this is a time that they may be the most broken, the most vulnerable. Let's help them. Let's show them that there's a different way. Post-release period is the most critical time. So once a person hits the street, within the first 2 weeks, 3 weeks is tough. I'm trying to get a phone. I'm trying to get bus fare. I'm trying to reconnect with my family. Can I even go back to where my family is based on my charge or based on if I was convicted and based on whether or not the community will even accept me back just off of the rumor that something has happened. So post-release is a critical time. So catching those individuals immediately when they're released, and really if we can catch them beforehand, develop that solid relationship with them so that they can feel that once I hit the concrete, I know that I can call this place and they're going to help me. Having academic and community and correctional partnerships are essential. The correctional setting has to work with individuals right there where they are, but they know incarceration. On the other side, the community and the academic side, they know areas of growth, empowerment. Let's partner these together in order to make it safer while individuals are incarcerated, but then also to be able to make it a little bit easier for the transition from prison back to the community. And again, community partnerships and are more than just agency MOUs and contracts. You have to have more than that, more than just the paperwork. It's actually banding together and working together. Thank you so much.
Thank you for an excellent talk, Jeanette, and glad we got your technical issues straightened out. So wonderful, yay. We're going to keep things moving along. The next section, we're going to be talking about JPrEP, exploring and preparing for PrEP implementation in diverse correctional settings, and immediately following release. We're going to be hearing from Chad Zawitz and Russell Brewer. Turn it over to you guys now.
I apologize. My computer is a little sensitive today. Thank you, everyone. Thank you, Jim, the Choice Agenda, for the invitation. I'm Russell Brewer, and as I mentioned before, I'm a research faculty at the University of Chicago. I've been doing this work focused on individuals who have been impacted by the criminal legal system for the last 14 years, and it really started off with just wanting to explore the impact of incarceration among Black sexual and gender minority populations in the United States. I was a former HPTN 061, a former HPTN scholar. I was able to explore, participants that how incarceration impacted the lives of participants enrolled in the HPTN 061 study focused on Black sexual and gender minority populations in the US. And we saw a high impact of incarceration. 60% of the sample indicated that they had a previous incarceration history. And I think that really set the stage for my interest and passion and drive to really make a difference in this area. So it started off with that exploration, but then it also went on to how can we develop programs focused on these populations, particularly in correctional settings. And I started doing that work in Louisiana when I was the director of the HIV STI program, and I started building relationships with community-based organizations and jails and prisons in Louisiana, particularly in New Orleans and Baton Rouge. And we have some of the partners here on the webinar today who will also talk a little bit more about their work. But then the work I was doing in Louisiana was really focused on people living with HIV in correctional settings. How can we enhance access to HIV care, treatment services post-release? So we developed and tested and evaluated several interventions in that area, for example, to include navigation, case management, supporting the needs of individuals living with HIV who are coming out of correctional settings. And when I moved to the University of Chicago and I joined the faculty there, I started building relationships with Cook County Jail, Dr. Zawitz, who's also on the webinar today, and we'll be sharing some of what's going on in Cook County Jail as it relates to PrEP and HIV prevention. But I really wanted to look at how we can also do a better job around PrEP implementation within correctional settings and really support the needs of individuals who may be vulnerable to HIV. So I wanted to share with you some of the results from some of the first exploratory work that I did in this area. It's the JPrEP study. It was funded by NIH and our CFAR, Center for AIDS Research here in Chicago. So we really wanted to explore and examine the HIV prevention landscape in Chicago, New Orleans, and Baton Rouge jails, given, that's where I had connections. I had built connections in those areas. And this study was conducted from 2019 to 2022. And we really wanted to look at acceptability, barriers, facilitators to the implementation of PrEP, different PrEP modalities to include oral PrEP, long-acting injectable, or the provision of a 30-day PrEP e-prescription post-release to really inform future work in this area to really build a supportive environment within correctional settings, but also immediately following release, as particularly for those who may be vulnerable to HIV. So as part of this study, we conducted an environmental scan of different websites. We had informal discussions with key stakeholders in Chicago and Louisiana. And we did more formal dyadic interviews and one focus groups with stakeholders. So that included stakeholders who were in the jails, but also stakeholders who were at community-based organizations, and they had access to jails in those jurisdictions that we were doing the study. We also conducted in-depth interviews with HIV negative young Black MSM and Black transgender women, 18 to 34 years of age, who reported a previous jail stay, because we really wanted to get a better sense of, you know, what they knew about PrEP, what they thought about PrEP, how would they feel if PrEP was offered in jails, in correctional settings, and immediately following release, and how would it benefit them? And we continue to have discussions with stakeholders about changes in the HIV prevention landscape, because it's constantly changing, and we have to continuously monitor and track what's going on in order to inform our efforts. So what did I learn from New Orleans? Well, in New Orleans, the county jail is called the Orleans Justice Center. So at the time when we did this study, the average daily population of the Orleans Justice Center was 750, and that has increased over the years, and Louise is going to share a little bit more about that in her presentation. We also know in Louisiana that state prisoners are also housed in local jails. So there's an estimated half of detainees in state custody are serving their time in local jails. So these are considerations we have to take into account as we're designing PrEP programs within these settings. We also learned that the average length of stay in the New Orleans jail is 47 days. So jails are typically short stays. So we also have to think about, well, how long are folks going to be here? How quick can we start providing PrEP or providing education and supporting and assessing needs in order to promote more continuity of care post-release? We saw that the detention rate was 4 times higher among Black individuals compared with white individuals. We also found that opt-out HIV, STI, and Hep C testing was provided in the jail in New Orleans. There was also an existing reentry coalition that met regularly, and the coalition consisted of individuals, providers from the jail, also individuals from community organizations and other HIV service providers. And the discussions were typically centered around supporting the needs of criminal legal involved individuals who were living with HIV. So I think there was certainly a huge opportunity to expand that conversation, to make it more status neutral, and start talking about, well, how can we really serve the needs of individuals who may be vulnerable to HIV? We also saw that there was certainly an opportunity to leverage existing infrastructures, for example, case management systems within community-based organizations that could also track and monitor the needs of folks who have been impacted by the criminal legal system who may be vulnerable to HIV. What did we learn about Baton Rouge? So in Baton Rouge, there is the East Baton Rouge Parish Jail. The average daily population is 1,200 detainees. So at this time, this was more than the population in New Orleans, and 40% of detainees were released in a month. So you can see the picture here that individuals in jails typically do not stay as long as individuals in prisons. And the provision of HIV STI testing was different in Baton Rouge. A community-based organization was actually providing the screening in the jail, and PrEP was not currently provided. And also in New Orleans, PrEP was not also provided. And we saw that in general, participants with lived experience who reported a jail history, they were largely receptive to all forms of PrEP modalities. So they liked oral PrEP, they liked injectable PrEP, they liked the idea of a PrEP prescription post-release. But there were also some things that were mentioned in terms of potential barriers, such as HIV-related stigma. They didn't want anyone seeing them taking a pill or something But then also those were things that might be addressed with long-acting injectables, for example. And as that is ramped up within these settings, they also, folks with lived experience also stated a high need for PrEP in jails and immediately following release. And we saw that one of the community-based organizations had an established relationship with probation and parole. So we're really trying to build the picture of what's going on in Louisiana, but also in Cook County. And Dr. Zawitz is going to talk a little bit more about what's going on in Cook County to really inform future programs that are focused on PrEP implementation and expanding PrEP to populations that need them the most. So what did we learn? I can't see that part so well, but I think I have to move 1 second there. So I think, as I mentioned, it's important to understand and monitor the landscape, what's going on, because the landscape continuously changes. What's going on in terms of policies and programs? Who are the partners? Who are the movers and the shakers? We also, sometimes all it takes is just identifying one champion who can help support what you're trying to do in the jail, or a community organization that has access to the correctional setting that you're trying to do this work. And we've identified 2 key players in the New Orleans and Baton Rouge area who are Frontline Legal Services and Capital Area Reentry Program. And they're also going to talk a little bit more about their work as in this webinar. I think you can also start small in this work, starting with education, HIV PrEP education, moving to testing, moving to linkages and integrating it with linkages to HIV and PrEP services post-release, but then also looking at how you can improve the provision of PrEP within correctional settings. I think certainly there are some common barriers that prop up in terms of implementing this in jails and prisons, and that includes cost. How much is it going to cost correctional settings to do this? The time burden, like how is that going to impact staff, providers, but also other staff that work in these settings, and what are the extra things they may have to do to support this new program? Are there any space needs? And as I mentioned before, also thinking about HIV-related stigma and how we develop interventions that are more status neutral, that focus more on a holistic health needs. And I think it really takes time and patience to do this work. And I think we really have to think about the 3 S's, status neutral, how we can integrate, PrEP into what we are already doing within correctional settings. I think we certainly need to think about the social determinants of health, as Ms. Jeannette mentioned in her presentation, as we're thinking about housing, employment, how do we support the needs of folks that are leaving correctional settings and need these supports in order to stay engaged and retained and live life to the fullest. But then also how the interventions we develop can support folks within correctional settings, but also post-release. Now I'm going to pass it on to Dr. Zawitz.
Thanks, Russell. Good day to everybody. I know we have people from various time zones and all around the world. Thank you all for attending. And Russell, will you advance the slides for me if I announce my next slide? Is that okay?
Will do.
Okay, doke. Again, my name is Dr. Chad Zawitz. I'm an infectious disease internal medicine physician working out of the Cook County Jail here in Chicago. I've been working in carceral health for, gosh, this is my 21st year, all in this facility here, and it's been a real roller coaster I wanted to share, as Russell and Jeannette mentioned, that we have had a long-standing and robust, I'm going to call it an academic love affair, a partnership with our University of Chicago colleagues, and it's been marvelous working with them, and I'm really grateful to have been able to be a small part of their important work. This morning, in my 10 minutes or so, I'm just going to give you a brief overview of the Cook County Jail here in Chicago and what our experience with PrEP and PrEP services has been to date, and some of the triumphs and some of our ongoing challenges. So let's start with a little quick snapshot. The Cook County Jail, we are the third largest jail system in the United States, following LA and New York City. We're at one time the largest single site correctional facility anywhere in the country, and due to social justice movements and criminal justice reform and a bunch of other things, I've seen our jail population shrink from when I started in 2004, about 11,000 plus detainees, or we call them now IICs, individuals in custody. About 11,000 IICs here in our jail is now down to an average of about 5,000 per day. The ethnic breakdown is and sex and gender breakdown is about 90% male and about 70% Black or African American. Within our, and by the way, that one white building you're looking at on the screen there, that is not the jail. That is one building on our 100-acre compound that has, I think, 15 buildings of varying size. This one that you see on the screen is our building called Division 11. And when this building is full, which is almost always, it holds by itself 1,500 individuals within that sort of clover-shaped building. But the whole compound is 100 acres. It's over a massive amount of Cook County territory. So just to give you some perspective, it's not just one building with bars and cells. So we at Cook County Jail have a health services entity known as CERMAC Health Services. It's a subsidiary of Cook County Health, so the umbrella health organization for all of Cook County, the Cook County Hospital, known as John Stroger Hospital, the freestanding infectious disease and HIV facility known as the Ruth Rothstein Core Center, Provident Hospital, and a variety of county health clinics scattered all around all of Cook County. We are also part of that health organization. We're just physically located here on the jail compound, providing comprehensive health services for our IICs. The last bullet point is actually a little bit hard to explain. I'll try to keep it brief. Pre-COVID, because it seems like everything is now pre-COVID and post-COVID, we had a roughly trimodal distribution of when people would be, in terms of timing, when people would leave our facility. About a third were out within 2 days, about a third within 2 weeks, and a little less than a third within 6 weeks, leaving about 5%. That could be for much longer periods of time. That was pre-COVID. Since COVID, there's been a whole bunch of changes, the most significant of which happened about a year ago, something called the Safety Act here in Cook County, or actually the state of Illinois. Long and short of what that is the state of Illinois in jails and prisons has eliminated cash bail and cash bond, sort of leveling the playing field. And what that did was basically say, when someone is charged with their crime and arrested, before they ever get to the jail, the courts will say, and I'm again paraphrasing a much more elaborate process, if the nature of your charges are dangerous or violent or pose some sort of threat to the public, jail, and there's no bail and there's no bond, and you will sit in the jail until your day in court. And if the nature of your alleged charges are such that they're perceived to be somehow less of a threat to the public, trespassing and shoplifting and things that are considered nonviolent or non-dangerous or whatever, then no, you don't need to sit and wait in jail until your court date. You still have to come to court, but you can do that from home. So what happened was many of the so-called alleged nonviolent and other misdemeanor type of arrests were no longer being physically brought into our custody setting, and that actually condensed our jail population somewhat since last September as well. Next slide, please. Maybe I can advance it. Okay. Now I'm going to shift gears and talk a little bit about what we do in terms of STI and HIV screening, and then talk about what we do with PrEP in our jail. For screening, at our intake facility, meaning our newly arrested, newly brought onto the jail compound individuals, when they are processed, they have the custody part where they take their fingerprints and IDs and ask them a bunch of custody related questions. And following that, they're referred for health services. And part of the health services initially is opt out for a variety of sexually transmitted infections. We are currently testing for HIV and syphilis and hepatitis. It says Hep C screening on my slide, but let me give a shout out that we screen for Hep B and C. So it's HIV, syphilis, Hep B and C with blood, gonorrhea and chlamydia with urine. And for the females who enter our compound, in addition to that, opt-out will include trichomonas screening for our ladies. We have all of our specimens are sent to the Stroger Cook County Hospital for processing overnight, with the intent that our intakes occur late afternoon and into the evenings most days. The specimens are processed overnight, and by the next morning, we have a spreadsheet with a list of all of the results, positive, negative, or indeterminate, and then those can be reviewed and shared with the responsible medical provider on our compound to ensure treatment and notification occurs usually within the first 24 hours. The caveat being weekends, that is not happening. The specimens are procured and tested and resulted, but it's really 5 days a week where we have providers on staff that are actually communicating results and treatment to our patients who are still on the compound. Now, I said this is opt-out testing, and for those of you, I think everyone on this call probably knows, but in short, opt-out means we are testing you for these things unless you decline. It is not, would you like to be tested? It's not offering them the test. It's telling them, you, as part of this process, are already going to be getting these tests unless you decline. And as you can see from the slide, and the numbers change from month to month, but it averages about 30% of the males accept the testing, and about 40% of the females accept the testing. Depending on if you have a glass half empty or glass half full viewpoint, you can see those numbers and decide if you think those are fantastically good or leave a lot of room for improvement. Now, in terms of PrEP, so we do offer and have PrEP services and PrEP medications available on our compound. Right now, we are only offering oral PrEP, and due to our county formulary, we are only able to provide, forgive me for using brand name here, but Truvada, which is TDF FTC, or tenofovir FTC, fixed dose tablet. So it is a one pill PrEP option. There may be medical exemptions for someone who, for whatever reason, maybe can't take that very specific brand, but ultimately that is what our formulary offers, but we do have it. We have on any given day about 12 individuals who are currently prescribed and receiving PrEP physically here on the compound. Our jail has roughly 33, 34 medical providers available. Of those, 20 of them are potentially eligible to prescribe PrEP. And you might say, why isn't everybody? Well, they all are technically, but about a third of them work in our urgent cares, effectively an emergency room. And much like in the community at large, I think right now it is not standard of care to be prescribing antiviral medications, including PrEP, in emergency rooms. And maybe there's some public health folks on here who will beg to differ, and look forward to hearing opportunities for considering PrEP in an urgent care or emergency room setting, but I just mentioned it for the purposes of what are we actually doing right now. About 2/3 of our providers who provide primary care services are the ones who are responsible for actually writing for PrEP for our patients. So how is the decision about PrEP made in our jail? Well, there's basically three populations. One are the folks who are prescribed it and taking it in the community, and when they enter the jail, they say, among other things they're asked, I am prescribed and taking PrEP. I would like to continue it while I'm in custody. And the answer is yes, we will write for it. However, you're going to get our formulary, which is this. The second group are individuals who may be PrEP eligible, who have a clinical encounter with the provider sometime during their jail stay, and they say, I've heard of PrEP, or I'm interested in PrEP, or the prescriber can then talk to them and counsel them and then decide if PrEP needs to be started, whether here in the jail, and we can and do initiate PrEP here in the jail. And then the third is provider introduction of PrEP, meaning a lot of patients don't even know about PrEP, or they're not aware that they may be someone who may be susceptible to acquiring HIV, they're PrEP eligible, and the provider introduces the concept to them. So those are the three main populations. Next slide, please. Okay, what are some of our barriers to doing more of this or doing a better job? One of them is what I'm calling limited provider buy-in. And I feel like that's almost sounds like I'm throwing providers under the bus when I say that. But despite the fact that we have 20 or so providers who work in primary care, who ultimately are the prescribers of PrEP, I'm an infectious disease specialist. And I see the patients when my colleagues didn't write for PrEP and the patients have HIV and they get to me. I don't generally see HIV negative individuals to have those discussions other than to tell my HIV positive patients, maybe your partner or your spouse or your significant other or the person you might be having sex with here in the jail might be PrEP eligible. Those are conversations I have, but it's our primary care providers. Despite numerous in-services, not everybody is fully on board. It's not that they're hesitant or have some sort of moral platform. It's just not everybody has been actively engaged in these conversations with our patients fully. So that's what I mean when I say limited provider buy-in. Overburdened staff, I think every single person on this call can say I'm overworked, I'm underpaid, I'm this, I'm that, and it's just so much. Well, the truth is that there's some truth to that. We have many competing priorities in limited clinic time and encounters with our patients, and having a PrEP education and prescription conversation is time consuming, and it is not always a top priority for our medical staff in limited clinic time. So that's what I mean by overburdened staff. I think Russell mentioned this a moment ago, but there is stigma associated with PrEP, if you can believe it or not, especially when we're using one very specific brand, blue pill. It is recognizable. There are individuals who know what it is, and others here on the compound, especially in some of our, we call them PC or protective custody tiers, where many of our MSM and trans patients are co-housed. They're aware, and if they know or see somebody is taking the blue pill, it has a layer of added stigma. For example, why do you need that pill? What are you doing in here that you need that pill? And lastly, during COVID, as I think Jeannette mentioned earlier, there was some restricted access physically to our jail to people who are not considered essential personnel or employees of the jail, and it had some impact on our partnerships and our physical access to our compound by folks who were coming in here and meeting with our patients, interviewing them, providing PrEP education. We're gradually restoring these things, but just to mention that those things, they happened. What are some of our facilitators going forward? Well, as Russell mentioned, there is a high acceptability for long-acting injectable PrEP. And by eliminating the blue pill that is visible and having a discrete encounter with a nurse so they can get a dose of injectable PrEP, this has the potential to reduce PrEP-related stigma. We have a P&T committee, like I think many large organizations do. We can't just say, I want PrEP, snap my fingers, and it gets added to the formulary. There's a formal process to do this, and it's time-consuming, and just as a sidebar. So we're working on that, but right now it's one of our barriers to getting long-acting injectable PrEP on the menu here. And then lastly, as mentioned in the J-PrEP study, we have high acceptability for e-prescribing. So remember, this is a jail. We don't know when they're leaving, but we do know that when people leave, if they're on PrEP, they need to continue it when they get back to the community. We are actually not allowed by law to physically hand them their medications. I get this question all the time. Well, why not? Read up on the Illinois Pharmacy Practice Act, and that's a whole other lecture to talk about that. But while we can't give them physically their medicine, we can e-prescribe it to a pharmacy of their choice, or if they don't have a pharmacy, we can send it to our John Stroger Hospital outpatient pharmacy, and patients can go there to pick it up upon release. Next slide, please. So what were some of our lessons learned? Well, I can't say that we're the only jail or prison anywhere that is doing this. I just know that we've been doing it for quite some time. Most people on this call know this, but PrEP isn't new. PrEP's been FDA approved since I think 2012. So we're now in our 12th or 13th year of having this available as an option to protect our HIV at-risk population. We weren't resistant, but we were not early adopters of PrEP out of innovation or some strong desire to push the envelope in custodial health. Russell wanted me to tell the story, but in the limited amount of time I have, I'm going to just say it was collaborative and with the help and some needling and pushing from some of our community partners that we began implementing PrEP here at the jail. If we have time later in the talk and someone has a question, I can tell you a little more about that. As mentioned, our partnerships, both academic, community, and correctional partnerships, these are all essential to advancing the provision of PrEP within correctional settings. We can kind of do what we need to or what we want to here in the jail, but they're leaving us sooner or later. They're either going to go to prison, get extradited to another county, and we don't know where they go, or that most of them leave and go back to their homes or go back to their communities. And so having built or attempting to build these partnerships from every angle is essential if we want PrEP to be successful. Just sprinkling pills on them when they're in the jail serves its purpose while they're in jail, but it isn't necessarily meaningful in the long haul. So those partnerships are essential. We have many key populations. I think we spend a lot of time focusing on MSM and trans individuals, but we shouldn't forget that there are many other PrEP eligible populations, and that includes I should say OTP, excuse me, opioid treatment program, and MAT patients. That's our substance use treatment program, particularly our injection drug use population. Many of them are PrEP eligible, and there's a wonderful opportunity to consider integrating that into our substance use programming. Anyone who is diagnosed with any type of a sexually transmitted infection, regardless of the route by which they acquired it, they are potentially PrEP eligible. Anyone who's asking about PrEP or who wants to continue PrEP while they're incarcerated, these are all populations, and some of them are a little bit overlooked because we spend justifiably a great deal of our time, energy, and focus on very specific populations like MSM and trans individuals. Provider and staff in-servicing and repeating this is essential to PrEP implementation and sustaining it. We've learned this here in the Cook County Jail. When PrEP was first approved, we had lots of lectures. We had guest lecturers. We had me. We had webinars. We had everything to get our staff on board, educate them, help them understand the correct way to manage PrEP in our facility. But there's staff turnover. There's sort of academic and mental erosion that happens over time, use it or lose it. So I'll emphasize that it's not, train it, set it, and forget it. You have to continually repeat this messaging, and you'll have greater success in having your providers on board with navigating the PrEP landscape. Speaking of PrEP navigation, having PrEP navigators, discharge planners, case managers, linkage coordinators, who can help with discharge planning to PrEP services is essential. I'm not going to pretend that we're overflowing with all of the people I just said we need, but they are a key part of this because, again, when patients are leaving custody settings, well, doc, that's great, but what do I do when I get out of here is a question I hear all the time. So that's a primary purpose of those folks. And lastly, as I mentioned, we are fully aware of long-acting injectables and all of the real amazing potential that comes with them, but they are not currently available at Cook County Jail. It's going to be a laborious and lengthy process to get that approved here, but we will continue to advocate for that. I think I went a little over my time. Thank you so much for your attention, everybody. I hope you enjoy the rest of the program. Let me hand this back over and look forward to questions at the end. Have a good morning.
Thank you so much, Chad. Before you disappear on camera, we have a couple of quick follow-up questions I think are specific to you, would be good to dispatch. So as brief as you can answer them, and if you can, we can add more color commentary in the chat perhaps. The first question is, what percentage do you know of the detainees opt out of being screened upon admission? And are they offered screening upon exit as well?
Sure. I think earlier on one of my slides, we put the numbers up for you, but about 30% of the men accept some of our testing, some or all, which means 70% are declining to be tested at intake. And for our women, about 40% accept testing, which means about 60% are declining. What I can say about downstream testing is this. Testing is available at any time when they're here in the jail. The individuals in custody can request to be tested. They can put in what's called a health service request form and say, I want to be tested at any time, and we will test them. The second is if they're with a medical provider and for whatever reason decisions made to test, they can be tested. So there is downstream testing available, but exit testing is not done, and it's impossible for whole bunches of reasons, which is a whole, again, can talk to you after class about that. It's not possible. So we do not do exit testing from our jail. Was there another question?
Yes, I'll do one more quick question and then I'll just direct you to the chat. Anu has a question about the 1115 reentry waiver. But before you can do that in the chat, hopefully. But folks are asking, how is PrEP paid for while persons are in custody? Is there a quick answer to that?
Taxpayers of Cook County, the same way that all medications and all healthcare is paid for here in the jail. Our individuals who are in custody do not pay for anything. We pay effectively sticker price for everything we prescribe and administer here in the jail. So you can thank the deep pockets of the citizens of Cook County. They pay for it.
Thank you so much, Chad. Thank you for the great work. And if you or others can address the question from Anu in the chat, that would be great. And now we're going to bring back our friend Russell, who's going to be talking about JRISE. And just remind Russell and our next two speakers of the time. We are shortly after 9 or 10, depending on what time zone you're in. Or actually, Russell's at 7 in the morning on the West Coast. So just try to keep to time for these final talks. Thanks so much.
Yeah, thanks, Jim. I'm just gonna give folks maybe a flavor of the JRISE study. So that this study kind of it builds on the JPrEP study, because with JPrEP we examine the landscape, what's going on, and then with JRISE we're really looking at how we can implement interventions and supportive strategies to improve HIV and employment outcomes among Black criminal legal involved populations. So I'm just going to talk a little bit more about that study. So JRISE stands for Relevant Interventions and Implementation Strategies to eliminate the social and structural barriers to HIV services for Black MSM and other key populations. So for this study, we're not just focused on improving access to HIV and PrEP care in community, but we're also focused on improving employment outcomes for this population, knowing that employment is a major barrier to engaging and staying in care, but then also it's joblessness is a major factor also in recidivism. So this logo that you see was actually developed by our community advisory board that we've established for the study. JRISE is a 5-year study. It started last year and it's funded by NIH. And as I think you're starting to see how the work is moving towards more of a status neutral approach, or how we can integrate PrEP into the work that was already going on in Cook County Jail and in some of the other jurisdictions. So JRISE is implemented in 3 ending the HIV epidemic jurisdictions, New Orleans, Baton Rouge, and Cook County, given our history of doing that work in those jurisdictions. And it's being implemented in several correctional settings, and it's such as jails, probation, and parole, but then also in community. And we're focused on Black MSM, Black cisgender women, and Black transgender and gender diverse individuals, really based on our ending the HIV epidemic priorities. These are the 3 JRISE interventions. I'm just going to touch on them briefly. So the first is status neutral health navigation. So essentially, we are serving individuals living with HIV and who may be vulnerable to HIV. And health navigation is provided over a period of 6 months. And then the second intervention is status neutral employment navigation, right? So that intervention is provided over 12 months, and it's really focused on supporting employment and career development for participants in this study. And the third intervention is contingency management, or the provision of financial incentives of up to 140 for specific HIV care treatment and prevention milestones over a 12-month period. We tested this approach in Louisiana in the past, specifically among people living with HIV. And we really saw some promising results around retention and retention in HIV care. So for this study, we're looking at effectiveness, but then also we're looking at implementation. What are some of the barriers? What are some of the facilitators? We're also examining key implementation outcomes for this study. So we are conducting a type 2 hybrid effectiveness implementation trial. So participants will be randomized to health navigation or health navigation plus, which includes health navigation, employment navigation, and the contingency management intervention. And they'll have an equal chance of being randomized to one of the two interventions. And our goal is to enroll 350 participants in the study across the 3 jurisdictions. So we'll be working with Chad, we'll be working with Gjvar and Louise at Frontline Legal Services and CARP in Louisiana to implement this study. That's just a flavor of the study procedures. So participants are randomized to one of the 2 interventions. We after completing a baseline survey, and we also conduct 2 follow-up surveys. We have several outcomes for this study, ranging from primary, secondary, and exploratory outcomes. And many of the outcomes are focused on the HIV and PrEP care continuum, but we also have outcomes that are really focused on employment, and sustained employment over time, given that this study is also focused on employment. This is the eligibility criteria. I just wanted to point out that for this study, we really expand the definition of criminal legal engagement to also include individuals who may have been stopped, searched, physically or verbally abused, or had some type of negative interaction with law enforcement that maybe did not necessarily lead to an arrest or jail or prison time, because we understand, or we've seen that this leads to increased stress, increased trauma, increased mistrust of systems, and less likelihood of accessing and staying engaged in services. So we really also wanted to serve those individuals as part of the JRISE study. So as I mentioned, JRISE is going to enroll individuals living with HIV and who may be vulnerable to HIV in each of those 3 jurisdictions. This is just a little flavor of, our the framework that we're using and some of the things that went behind designing the various interventions. As I mentioned before, high unemployment among this population it is high, but also joblessness is the single most important predictor of recidivism. So how do we start really creating interventions that address, not only promote access to PrEP or HIV services, but they also start to address the social determinants of health. And we're also looking at how this status neutral intervention also plays a role in addressing HIV-related stigma that we've seen from previous work. I think this whole framework around status neutral really attempts or aims to leverage the missed opportunities that are present if we are just focused maybe specifically within correctional settings, maybe around one particular thing. So I think really integrating PrEP within those programs and interventions, I really creates a more holistic approach to the work. We have 8 implementation strategies. So these strategies are the things that we're doing to support the integration and the adoption of the interventions. They include, for example, we've hired employment outreach specialists at each of the different jurisdictions. They're based at the implementation partners, so at the community-based organizations, and they're the ones who are building relationships with employers and temporary staffing agencies to really support the employment needs of returning citizens, and also expand our community resource guide so that the navigators can refer folks to some of those relationships that are built over time. We're providing training, we're monitoring the distribution of financial incentives. We're conducting fidelity assessments to make sure that the interventions are delivered as designed. These are our main study partners for the study. I'm working with Dr. Zawitz in Cook County Jails, and we're leading, and our team is also leading AIM-1, which is focused on effectiveness. Frontline Legal Services and is the implementation partner in New Orleans, and they're working with the New Orleans jail. CARP is the implementation partner in Baton Rouge, and they're working in probation and parole. So as you can see, we have a variety of partners that are involved in this work. These are some of the tools that we've already developed to help make things easier for our interventionists, for the folks who are conducting the research on the ground, to really support the study. So we started enrollment for the study in August. We've screened 152 individuals as of October 18th. We've enrolled 9 individuals in the study across the sites. So just, you know, just a recap on JRAS. I think it's really important that, yes, it's important to integrate PrEP into the work that we're doing, I think, but also it's important to really address the social determinants of health. So that includes things like employment and housing and some of those things that really impact long-term engagement in services. Working with prisoners takes time to secure the necessary approvals to do this research. We expect that there will be adaptations. We will make changes during the course of the study, so we will track some of the changes that we are going to make. We will also assess experiences of our participants in health and community service organizations, so we can get a better sense of, we're making our intervention staff are making these referrals, right? But we also want to know, what are the experiences of participants when they go or try to access these services? So I think that's critical. I think we have a very flexible approach when it comes to HIV prevention and PrEP. We really want to include individuals in this study who've never heard about PrEP or taken it. They're curious, they want more information about it, and maybe not necessarily they meet more of the traditional criteria for PrEP. I think there's certainly opportunities to leverage participants to implement the employment outreach specialist strategy. So that's the individual who's building relationships with employers and temporary staffing agencies. So I think there's really an opportunity to leverage participants to do this in the future. And certainly we hope to expand the work to address other social determinants of health with community partners in Chicago, for example, to look at how housing first interventions and strategies to really improve housing outcomes among this population. I'd like to acknowledge the funders, participants, and our partners, but also there's my contact information for any questions, rbrewer@uchicago.edu. So I'll stop there.
Thank you, Russell. And let's hear from one of these the first of the JRISE partners we're going to listen to or hear from, Gjvar Payne, followed by Louise. And just remind folks of our time. We have 13 minutes left for this webinar. Go ahead, Gjvar.
So actually, it's going to be Louise first. Louise?
So I'm Louise Bienvenu. I'm the co-executive director at Frontline Legal Services, and we are certainly honored to be chosen as a study partner for this JRISE program. I'll take about 2 minutes so we can move on quickly. My slides are very print heavy, and they will be sent out to all the participants in the program today. So I'm just going to hit some high points. So I've been working as an attorney providing legal services to people living with HIV for over 20 years. And we started Frontline to specifically bring services to folks in prisons, jails, and other hard to reach individuals that are living with HIV. And over the last 8 years, we expanded our services to include peer support, case management. We have a CPA that helps with tax preparation. We provide housing assistance, peer support, employment support. and other social programs along with the legal programs. And we are a very small organization. We have an attorney, we have paralegal, we have case managers, but no full-time employees. So we were invited to be a study partner because of our unique work within the corrections, with people living with HIV, and also because we are a law firm. We have access to prisons and jails when no other visitors are actually allowed in at all. And especially like during the COVID pandemic, there were no visitors allowed in jails and prisons, but we were able to set up telelegal visits, telehealth visits, and meet with clients over systems that others couldn't reach. So our implementation site is the Orleans Justice Center, as Dr. Brewer discussed, and it was chosen as the implementation site and Frontline as the partner because we already meet with people living with HIV at the Justice Center every other week to assess for legal issues and other services and provide linkage to care on the outside. And so we've also, as we enter into the JRISE program, we've expanded our potential base by working with the Orleans Indigent Defender Program attorneys to recruit participants. And so if go to the next slide, Russell. And so I think Dr. Brewer already talked about what the situation is at Orleans Justice Center, and that they have about 1,500 inmates right now, and that the rearrest rate is at a high of 83%. And so that is part of an outcome that we hope to affect with the work that we do. And so next slide. And so Dr. Brewer asked us to talk about lessons learned and recommendations. And the first thing is, because we have worked exclusively with people living with HIV for over 20 years, this is a whole new, brave new world for us at Frontline. But what is exciting is that we have been providing all of the things to people living with HIV that we hope to now be able to progress into and expand to folks that are affected by or at risk to or vulnerable to HIV. And that it's a very natural progression for us to move into this expansion of our services. And also, although we've never worked with incentives and we've never worked with this type of intensive engagement along with the incentives to see how it affects income outcomes. So this data intensive study is very exciting. And the last point on my last slide is that we hope to utilize our community partners and our Department of Corrections and our Justice Center partnerships to advance the provision of PrEP within the Orleans Justice Center moving forward, as we all learn more about it and provide the education not only to the folks, the participants, but also to all of our community partners and the jail and the prison systems. So 2.5 minutes damn flat. So thank you.
Thank you so much, Louise. I'm going to invite Gjvar to come on camera and share his slides with us.
Yes, good morning, everyone. I am Gjvar Payne, and I am the Executive Director for Capital Area Reentry Program here in Baton Rouge. And we are a holistic health harm reduction and prevention organization that is boots on the ground. And our mission is to redefine reentry in Baton Rouge through holistic approach to routine screening, compassionate engagement, harm reductive services. And we have an array of different services that are on the screen. And you go to the next slide and we can shoot on through this. So we collaborate with our probation and parole office here in Baton Rouge, and we've been partnering with them since 2012, providing testing for HIV, Hep C, and syphilis, linkages to care for any positives that we screen, and we incentivize testing to those individuals. We've worked on various research projects with the being the Louisiana Reentry initiative, finding ways to link and keep HIV positive individuals into healthcare. We provide IDs, birth certificates, social security cards, because we realized that that was a great barrier to access to care. In 2015, we began recruiting for the Office of Minority Health, looking at the impact of linkage to medical care preventative services. Excuse me. And then just recently, we began to recruit for the JRISE study. Next slide. Okay. JRISE, as you heard, we're partnering. We use this partnership to gain better relationship with the parole officers, because the parole officers know their participants. You know, they know background information, and they usually refer like cases to us to help gain support. We get access to intended populations to assist in direct and supportive services, and we use that to continue to recruit and provide linkage to care services. Next slide. So what we've learned is that probation and parole are excited to have partners that are testing folks inside their facilities. We've been in talk of we've been in talk to replicate this model that we've used in this particular probation and parole, and to go into other parishes as well. Like I said, we issue a incentive for testing, just to get them to test and provide them with some kind of resources. It provides an entry point to speak directly to individuals with criminal justice involvement. It educates the probation officers on the resources, and it helps develop partnerships with healthcare access with probation and parole officers to assist folks. And so we've just really gained a really good partner throughout the years with our parole officers and probation officers, with the folks that continue to test, and those that we can get access to care after their stay in incarceration. And that's it for me. Any questions?
Excellent. Thank you so much, Gjvar. I'm going to ask all of our speakers to come back on camera. We can stop sharing the screen. Thank you, Russell. And we have a few minutes. I'm comfortable going a little bit over. So if people are cool with that, we can go a few minutes beyond the half hour. I'm going to ask if there's anyone in the room who would like to make a comment on camera. See your beautiful face, hear your beautiful voice. Please go ahead and raise your hand. And while we're sort of teeing that up, I think there's some people here who might want to do that. I'm going to just ask each of our speakers to think about one nugget you want to send everyone away with. We heard a lot of really great information, learned a lot about what you all are doing, the ups, the downs, the challenges, the opportunities. If you want someone to remember one thing from your talk, one thing, brief nugget, what is it? I'm going to go down the list from how we started. So Jeannette, that means you're on the hot seat. What is your one nugget you want to send people away with?
The one nugget to send people away with is, regardless of the circumstances as to how a person became incarcerated, they deserve the right to dignity, and for someone to utilize every opportunity to help them become their better selves, and that their voices need to be heard. And so those of us that have that position, we should do all that we can in order to assist that. Thank you.
Thank you, Jeanette. And you know, I just knew Gina Evans would take this opportunity, knowing her as long as I have. The lovely Gina Evans, please, your comment or question.
You know, I can hear you talking about me. Anyways, you know, that was low-key shade. No, I really appreciate Gjvar's last thing talking about providing probation and parole officers with resources. Like, I have a newly released nephew, as they're all nephews, and he was asking me questions, and I was like, ask your parole officer. So thank you for that. And we need to figure out how to make sure that's implemented all the way across the board, that we put that on the probation and parole officers to offer resources to the people, their returning citizens.
Thanks for that comment, Gina. And while the other speakers are thinking of your nuggets, I'm going to highlight this question that just came up in the chat, and I think it's something that we all think about when we think about PrEP or condoms or anything like that in a correctional setting. And so maybe this is something for Chad to address. How did you overcome the overarching concern that allowing inmates access to PrEP will, quote, promote sexual activity in the correctional setting? This is a huge hurdle. And then the second part of that question is, have there been efforts to offer PrEP to cisgender women in the correctional system?
Yeah, powerfully important questions, both of them. I guess the first is, we didn't have, that I'm aware of, any concerns or pushback or somebody saying you're promoting sex. We did have that when we tried to get condoms in the jail, but we've never had that happen with PrEP. But I always frame my answer to this, whether it's condoms, PrEP, or otherwise, is this: I'm not promoting sex. I'm trying to prevent diseases from being transmitted when people are having sex, because they are, and they're going to, and you're not going to stop it. So let's move past your moral platform or whatever it is that you have itchy, weird feelings about people having sex in jail. Let's move past that and be grown-ups in the room. Sorry for saying it like that, but sometimes you have to talk to people like a little more bluntly. And my answer is, I'm trying to prevent diseases from being transmitted. If it's a custody official who's saying this to you, my answer would be, it's your responsibility to prevent the sex from happening. So maybe you need to police your environment better. I don't really mean that. I just want to say, like, I'm not here to stop people from having sex. I'm here to prevent them from getting diseases if and when they do have sex. That's that answer. And for, at least for us, yeah, PrEP is offered to anyone who is PrEP eligible. Like I said earlier, we spent a lot of time talking about very narrow focused populations for good reasons, but many different populations are PrEP eligible, and that includes cisgender women. So I don't know if I'm going to call it an effort. I'll just say that it's part of our all-encompassing, PrEP eligibility program. So yes, it's available. I will tell you, I think I'm aware of exactly one cisgender woman who has received PrEP here in our jail since we started offering it and having it available. It's not that there's been huge uptake, but that's your answer.
And
I guess
thank you. And Chad, are you ready to give us your one nugget, our tasty, delicious nugget to take with us?
Tasty nugget. Probably old news to everyone on this. My nugget is, PrEP is a standard of care. It is the best, most effective tool we have to prevent HIV transmission, full stop. If you are not using, offering, or aware of PrEP, you are denying patients access to the #1 tool we have available to prevent HIV. That's my nugget. So use it or lose it.
Beautiful, Chad. Thank you so much. And since I saw Louise had a rather spicy comment there in the chat, Louise, what is your nugget that you're going to send people home with?
My nugget is that I'm just so excited to be able to bring this employment support to folks living with HIV and all of the folks that are affected by or at risk to contracting HIV. And that these types of studies, such as Dr. Brewer has put together, are game changers. And I saw in his notes as well that as we progress through this employment study, that the next on the list is housing. And so as we all talk about in the system, you know, housing is healthcare, housing is all, well, employment prevents recidivism. It is healthcare. Employment is healthcare. So that's my nugget for today.
That is a delicious nugget, and thank you for sharing that, Louise. We need a nugget from Baton Rouge. Gjvar, what's the nugget from Baton Rouge today?
Well, post-COVID, we have not been invited back to the jails yet. And so my nugget is, if you can't get in where the getting is good, you got to go where the next best level is. And so that's probation and parole. And so to access community partners and different organizations and community and build that trust and build that rapport with those individuals that work and that are served there.
Thank you, Gjvar. And we're going to circle back to the mastermind behind this webinar and the guy leading a lot of this really important research, Russell, all the way from the Pacific time zone.
I know, right?
What
No,
so early? So thank you for waking up so early with us today. What are your nuggets or nugget for our audience?
well, I just want to say thank you again to the Choice Agenda and Jim. And I just want to say that, I mean, we haven't, I'm not doing this work alone. I mean, you see who's all on this webinar today, and we really need to be intentional about this work, and we need to find ways to do this work. If that's finding a community-based organization that has access, like Louise's organization providing legal services, or Gjvar's organization, or finding champions in Cook County Jail like Dr. Zawitz, like it just keeps me motivated. It just keeps me like hopeful that we can continue to build. We continue to build from wherever we are, but we got to start somewhere.
Thank you so much. So everyone who's still in the room with us, hanging out a little bit longer, please give some love to all of our speakers, to Louise, Russell, Jeannette, Gjvar, and Chad. Thank you all so much for joining us today. And to the many of you who will be consuming this on your own time on the recording, a reminder that we'll send out a links to the recording, the slides, and a resource document with all the nuggets and the link nuggets that we've shared in the chat will be provided for you. And please stay in touch with the Choice Agenda. We have some great programming coming up. In about a month, we're going to be doing a great webinar in differentiated service delivery. So thinking about choice is not just choice in the biomedical product or products or interventions, but how those interventions are delivered. And then in December, to round out our year and to end the year on a high note, we're doing a webinar on anal pleasure and health. So please stay tuned for both of those. In the meantime, have a really wonderful rest of your day. If you can get back, have a little nap, Russell, and get ready for the rest of your day. I might take a nap myself. And to all of you who are, legit ready to go to bed, thank you again for being here. We'll see you on another Choice Agenda webinar real soon, I hope. Take care.
Thank you.
Goodbye.
Thank you, everyone. Bye-bye. Thank you so much. Bye.